Hello, everybody. This is session 4 in clinical decision making. Today we're going to talk about clinical reasoning. So, in the first lecture, it was more about just decision making in general. The second lecture was more about, okay, let's apply that a little bit to the medical setting. The third lecture was about some different errors and biases that we may have when we're making decisions. And then this is specifically um, how do we make a clinical decision in medicine? This is pretty practical, and I think um, this is really how we're making decisions. And if you can get good at this type of decision making, then it's more of just the step-by-step approach. How do we actually make decisions when we're seeing patients? Um, then you're going to become a better doctor. So today we're going to introduce you guys to the principles and importance of clinical reasoning. We're going to differentiate between the clinical reasoning process, um, between beginners and experts, and then we're going to just change it. We're going to go over some models and strategies for clinical reasoning that can help us, and then give some practical examples, of course, and we'll go through that together. Okay, in clinical reasoning, there is a few different definitions that you could say. Some people would just say it's the process of drawing conclusions based upon known or presumed facts. And so um, we have this information from the patient, or we have these lab values, and then we're going to draw a conclusion from that. This is a little bit longer of a definition. I don't necessarily want you to memorize a lot of these definitions like I've told you before. I know you guys are good at that, but I want you to understand the idea in general rather than being able to say word for word what the definition is. And so that's even why I'm giving you more than one definition, because it's not just one specific definition of what this means. So other people would say it's the range of strategies, or like a doctor is going to use a group of strategies to generate different possible diagnoses, to to test what tests that he's going to order, how he's going to verify a diagnosis, to um, maybe the strategies that he's going to use to decide what tests and treatments have more benefit or have more risk, and also to judge or to figure out the prognosis um, of for a patient. Or just in general, I like this one. Just how does a doctor develop an accurate diagnosis and prognosis for a patient? Just in general, clinical reasoning is how we're thinking to arrive at the conclusions that we're making. So the importance of this is really, like we talked about in the last lecture, is that diagnostic errors, or errors in the ways that uh, we're um, making when we're trying to come up with a diagnosis, are very, very common. And there's a lot of estimates, I think we've talked about this the last lecture, that approximately 10 to 15% of diagnoses made in a hospital, and this is a study coming from America, the first diagnosis or the assumed diagnosis is actually wrong. And you might look at it a different way and say, wow, 90% of the time the diagnosis is right. And that's good, but it's just not enough. And we said that before in the last lecture too. It's not enough because these are life and death situations, or even if we don't get the diagnosis right correctly, a lot of the time it can really affect someone's health negatively. These diagnostic errors are common in all fields of medicine: surgery, medicine, pediatrics, everything. And they also have major consequences. And a lot of times these errors have a higher morbidity, meaning it can lead to, has a higher chance of making a patient more sick than other medical errors. Like, rather than, like, even if you gave the patient the wrong dose of medicine, that's not going to have as much of an effect as if a complete wrong diagnosis was made and a different treatment plan was put into place because of the wrong diagnosis. And so it affects the entire care of the patient, rather than if someone gives the wrong dose of medication, hopefully they're not going to continue to repeat that same thing. And also, like if a person is in surgery and a surgeon does something wrong, normally it's something the surgeon knows about and hopefully can correct the problem, rather than I, rather than this diagnostic error, which just completely changes the whole treatment plan. And so, really, as we study this, and just knowing how we reason, how we think, how we're coming about making our decisions, it's going to make us a better doctor and a more effective clinician. And it also, as we do this, it's going to help us avoid these cognitive errors. And as we avoid the cognitive errors, like the ones that we talked about in the last lecture, it's going to decrease the number of diagnostic errors that we're making. So when we're creating a hypothesis, this is the first step in clinical reasoning. First thing we're going to do is we're going to collect all the data. So we have a hypothesis. We're going to collect all the data that we have. This can be from taking a history, or looking at labs, or doing a physical exam. And then we're going to interpret that data. So we're going to put it all together, all the things the patient has told us, all the physical exam, the lab results and everything, and we're going to interpret that and try to figure out what are the important parts of that information, and does this information mean anything? And then after we kind of look at the information, we might have some further questions, or some more of an exam that we want to do on the patient, or we might want to do some more lab tests or x-rays, something else to go back and verify it. And then we're going to just look in general, are there any other contributing factors to this information? Is there any other information outside of this that could explain this information that I'm not thinking about, or that could be affecting this information? And then we modify our hypothesis based on all those, and then we decide upon a treatment. And then we treat the patient, and then we assess again, of course, like how is the patient doing? Either we visit them again later in the day in the hospital, we call the patient, we have the patient come back to our clinic on another day or the next week and see how the patient's doing. And then we can also, as we're watching the patient, we can tell the patient, like, you should get better in a week. If they don't get better, then we can tell them this is what to expect. If we're treating cancer or something like that, we can kind of come up with an idea to tell them what to expect in front of them. So this is kind of a different way of looking at everything. So a lot of times we start with the patient story, what the patient's telling us. We just acquire all the data, like from the history, from the exam, from the labs. If we want, we can go backwards, ask the patient more questions, keep going down the line, and then we go to, do we feel like we have an accurate representation of the problem? And if we don't, we can always go back and get more data. But once we have a fairly good idea of the problem, then we can, and we'll go through some examples, so I think this will make a little more sense later. Then we can generate a hypothesis. I think it's this disease. So we have a patient, he says, I'm really tired and I'm losing some weight. We get some more lab tests or physical exam. We feel like, okay, I think we have a pretty good idea. We have a patient that's a 65-year-old patient that's lost 30 pounds over the last 6 months and has just been really tired. So we generate a hypothesis. I think this person has cancer. So then we're going to search for and select out an illness script. And an illness script is, we'll talk about this more later, but it's a, it's like a main summary of a disease. Like for example, for cancer, it's going to be a patient that's been losing weight despite, for no apparent reason. He's not exercising, he's not dieting over a period of some months or some years, like a long period of time. For illness script for strep throat would be a patient that comes in with a sore throat and a fever, but they don't have a runny nose or a cough. Just that's like an illness script. So as we're generating our hypothesis, we're trying to think, does this fit any disease process that we know? And then if it is, then we pop out with a diagnosis. And inputting into all of these is the more knowledge we have, it's going to help inform our decision. The context we're in, like is this in a hospital setting? Is it in a clinic setting? Is this a house visit we're doing? That is going to inform the way that we're making decisions. Like in a hospital, we're maybe going to think someone coming in with chest pain, we're probably going to think a little bit harder, is this a heart attack? Rather than in our clinic, we might be more likely to think that this is like a musculoskeletal problem. Um, uh, and so also our experience, have we seen these problems before, is going to inform this whole process. Um, and of course, like this process goes back and forth. You know, we come up with a hypothesis, we look for illness script. If we can't find anything, then we go back and we look for more data. We try to get a better representation of the problem, and then generate a different hypothesis, and then try to figure out, is this fitting anything that we know, before we come up with a diagnosis. So this process, this clinical reasoning process, can look different if you're in the beginner stages, or if you're a more advanced in this clinical reasoning process. So as a beginner, a lot of times um, beginners will use a more systematic approach. And so they'll gather as much information as possible until a diagnosis possibly emerges. Um, so, for example, like when you guys are doing uh, your OSCE examinations, a lot of times I'll find that the students are just more memorizing a set list of questions and just asking all of the questions, because a lot of times at the beginning you don't know which questions are the most important ones or less important questions, and so you'll just ask all of the questions, and that's what's going to help you figure out the diagnosis, and which is okay at first. So a lot of times at first we might use like a checklist, and so if we're thinking a person has a cough, we might have a checklist of questions that we ask, like when does it get better, when does it get worse, like all these different things. You know, you have the Socrates um, method. You can have, or just any checklist for any symptom. And so that can be really helpful at any time, but especially at this beginner stage. And so you can also, this would obviously, it takes longer to recognize a clinical pattern. And so maybe a person that's been through this clinical reasoning process for years and years and has a lot of experience might recognize a clinical pattern, or might recognize a disease process quicker than someone at the beginning, because he's seen this same pattern so many times. Um, so also a beginner is going to be more concerned about uncertainty, and what I mean is that they're they're more concerned if they don't know what the diagnosis is right away. Um, they're going to be more concerned about that, because they really want to make sure that they're not missing anything. So if we go to the next level, it's a novice. So this is still before an expert. This is someone that has some experience, but maybe not many years and years. So at this point, So this is someone that's like been in residency for a few years, or someone that's just yeah a few years of experience. So they have seen quite a few things before. They have a pretty good repertoire or pretty good of clinical patterns, like a pretty good amount of clinical patterns that they have seen and have memorized in their heads. And so a lot of times what they'll do is they'll abandon the checklist and not be as systematic. But the problem is that they still lack experience to identify all or most of the different clinical disease patterns. And so they're often tempted to make assumptions. And also they're a little more comfortable with not with the uncertainty. They're a little more comfortable with not knowing the diagnosis, but so they might even be overconfident at this stage. And this is probably the most dangerous stage to be in. I always say, like if you're first in the hospital, your first year or two, you're spending so much time to make sure you don't miss anything, and you're using checklists, and you're asking other people, and you're reading. And also, if someone has been a clinician for 20 years, they've developed a large group of clinical patterns that they've seen, and they have a lot of experience. Um, but this middle group, where someone's been practicing for just a few years, sometimes this can be um, possibly the most dangerous time to be in, because you might think, oh, I kind of have a good understanding of different things now. I'm not going to read as much or ask other people as much. And so you might be making some more errors because you still don't have enough experience to really notice all the different clinical patterns. Whereas an expert, and this is what we're all hoping to get to, is an expert can generate a high quality hypothesis. They have a focused connection with the patient, verbal and nonverbal, meaning they really have a lot of experience on how to talk to patients and how to read and understand what patients are saying, and also how patients what their actions might mean. If they're looking down on the floor a lot, maybe they're an expert clinician is not thinking about his checklist as much, so he can really look at the patient and focus on the patient and see that this patient is depressed or something like that. Um, and so he has all these clinical patterns of different diseases in his head, and also he's has a lot of inductive reasoning, which is like the quick thinking and reasoning from which he can develop a diagnosis. And we'll talk more about inductive reasoning a little bit later. Um, so this an expert a lot of times is comfortable with not really knowing the diagnosis immediately, so they're not going to worry about it. They're not going to stop. They're still going to ask more questions and do more tests um, until they know the diagnosis. But they're not going to worry so much at the very beginning um, if they have the diagnosis, and so they're able to be more relaxed and really maybe get more information and think more clearly because of that. So in general, their management is going to be more efficient because they're going to ask the right questions. They're not just going to ask every question on the checklist, but they're going to be more efficient and then in turn more effective with the questions that they are asking. And so they're also going to recognize, uh, yeah, like what features are most important and are most significant, and so they're going to focus their attention on those features rather than just if a patient has 5 problems. Sometimes it's hard to know like which one is the most important that I need to focus on, but with experience, you're going to get better at that. So now we're going to talk though about the danger of relying on experience alone. And so, what do you think is the danger of this? And so, if you have a doctor that's been a doctor for 30 years, he has a lot of experience, right? What's the problem? What's a possible problem of this? Like if the doctor was going to say, I have a lot of experience now, so um, like obviously I'm better at making decisions than someone in their first year. of being a doctor? What do you think is the danger of this? One thing is that a doctor uh, can make the same mistakes year after year after year, but he can be increasingly confident about his decisions. And so he's increasingly confident over time about his mistakes and not realizing even more and more that these are mistakes. And so this is the idea of that someone can have 25 years of experience, meaning he can continue to grow over his years of practicing, versus one other doctor, like if he has 1 year of training after medical school, and then he just goes and doesn't read, doesn't go to conferences, doesn't talk to other colleagues, and just does the same thing that he did in his first year, year after year after year. He doesn't really have 25 years of experience. He has 1 year of experience, and he's repeated that experience 25 times, but he's not growing, or she. Um, so it's so important as we continue to practice medicine to keep up to date. And that's what I love about being in an academic setting and with training other doctors, is that I can continue to be challenged by them, and and I can continue to be around new information, and then that enables me to provide better care to patients because I'm constantly learning and keeping up to date with the new information that's coming out, and I'm constantly being challenged by my colleagues and coworkers because they might have a different way of doing things, or they might have a question that they ask me that I don't know the answer to, so I need to go look it up. So different consequences of not keeping up to date are that if you're not keeping up to date, you're not going to be providing the most. Uh, there's going to be a lag in providing optimal um, care at your practice, and so you're not going to be able to put in to practice the most beneficial treatment options or most beneficial diagnostic options. Um, so really, your clinical practice becomes just driven by your opinion, what you think is best. And as we've seen, even in the last lecture, diagnostic errors are very, very common. And so it really takes effort and takes a lot of work to make sure that we are um, making the best diagnoses possible. Of course, patients are not receiving the best care this way. And there's also some legal and ethical implications, like if there's a new treatment that's better, or a new medicine that's better, and we're still, or maybe there's a medication that has been shown to be not beneficial, like we used to give aspirin to almost all adults, and now we know that that's actually a dangerous thing to do because it can cause a lot of GI bleeding, and it has a lot of different side effects. And so we're more careful with which patients we give it to now. But if you're not keeping up to date, you're going to continue to provide not good care, and you could even be sued for not providing the best care to patients. Ethically, I talk about this a lot. Like, God has put us in a very important position in patients' lives. Patients are coming to us and they're sick and they're fearful, and they have a lot of concerns. They're scared, and it's the ethical thing to do that we are going to be um, trying to do the best that we can do to provide care for these patients just as if they were someone in our family. Um, and part of that comes from keeping up to date and reading and going to conferences, talking to colleagues, um, and just continuing to grow. So, well, let's just pause right here. 1 second. Okay, now we're going to talk about some different models of clinical reasoning. Um, there's really two main ones. One is it's intuitive or non-analytic reasoning, We can say it's the gut reaction. It's impulsive, it's effortless, it's reflexive. It's kind of like saying like the first thing that comes to your mind. That's what we mean by gut reaction. Like how does it make you feel? What do you think in the first second before you've thought about it too hard? So this is like, we can say pattern recognition. Pattern recognition, we talked about that a little bit. It's like someone that is coming in with sore throat and fever with no cough or runny nose. Okay, a lot of times that is strep throat. Um, what else? Like a certain type of rash, possibly, that we've seen before. Um, a Someone that is having a wet cough, um, that needs to use 3 pillows when he's sleeping at night. A lot of times we're thinking this is a heart failure. So just these patterns that, like, someone says these things and we think, boom, the first thing that pops into our head is this certain disease. So it's highly context dependent, meaning it really depends on the situation that we're currently in, whether it's a lot of times if we're in a hospital, a clinic, the type of patient that we're seeing, a lot of times this will really change our gut reaction. Um, and it's highly error prone. Um, a lot of that we talked about the last lecture. Analytical reasoning is a more slow, deliberate, and purposeful effort to solve a problem. Um, I can say this is more fancy word, hypothetico-deductive. So there's a hypothesis. You start with a falsifiable hypothesis. So a falsifiable hypothesis is a hypothesis that you can prove wrong. Like, like if the hypothesis is um, there are aliens that are living on Earth, but we can't see them or hear them, um, or touch them or smell them, or we have no way of knowing if they're here. That's not a falsifiable hypothesis because there is no way that we can disprove that. So, like in, let's see an example in medicine. Um, if there is just any, I can't think of an example right now, but if there's anything that you can't disprove, it's impossible to disprove, then that's not what we're talking about. It has to be a falsifiable hypothesis, something that you can actually prove wrong. Um, and and then after the falsifiable hypothesis is created, we test observable data. Um, Sometimes this is a, a debate in how old is the universe or how old is the Earth, because people are trying to do this in a scientific way, but it's actually really difficult when you're trying to um, like create data that you can observe when it's something that was done a long, long time ago. So, like, when did a certain civilization live? Was it 1,000 years? Was it 6,000 years ago? It's really hard. Like, it's hard to do scientific data on something that old, but it's a lot easier when we're studying like medicine now. Like, does this medicine work? We're going to observe the data and see if it works. And so just in general, when we're thinking about this type of analytical reasoning, it's generally more reliable. And I mean, it probably makes sense to you intuitively why, but we're going to talk more specifically why it is more reliable. So these are different approaches, and that maybe fall along the spectrum of intuitive to analytical reasoning. We'll talk about Bayesian reasoning. There's a whole lecture about that. We'll talk about inductive reasoning today. This normative reasoning, we talked a little bit about that already. That's like where we're going to use research and evidence-based medicine to make our decisions. We talked about the different biases at the last lecture. And so these all kind of fall on a spectrum, but in general, some of these are going to fall more on the intuitive side, and these are going to fall more on the analytical side. So when we break it down into these two groups, the rational, analytical side versus the intuitive side, again, we're going to see this is a more formal response. It's more objective. It's more scientific. It's more verifiable. And it's just a more rigorous, critical way of making decisions. Versus intuitive, it's just a lot more subjective and flexible, and it's dynamic, meaning there's no specific rule on how it's done. It's informal, like there's not like a specific way that has been, this is how you do intuitive reasoning. And it's really just depends, like I said, on the context, like we talked about before. So an example of this is there's a patient that a doctor's seeing. It's a 24-year-old Chinese woman or a Chinese man was seen in the emergency department for weakness or for arm weakness and leg weakness and hypokalemia. And after that much information, a doctor says one possibility that comes to, I don't know if you have any different ideas, but one doctor says one possibility that comes to mind is hyperthyroidism. And then we see, this is the exam on the patient, we see their imaging here. So what process did this clinician use to come to that? And it really doesn't even matter if he's right or if he's wrong. Right now we're talking about what type of process did he use to get here. So there's this type 1 and type 2 processes. So they really used the this type 1 process, this intuitive process, like with minimal information, boom, he has an idea of a diagnosis. So the type 1 process is going to be heuristic, which is, we talked about in the last lecture a little bit. It means like you have like these shortcuts. And so his shortcut is he's using pattern recognition. So he's seen this pattern before, boom, he jumps to the diagnosis. He probably doesn't know why he does this, so he's not very aware, cognitively aware, or aware mentally why he's making that decision. He's just, boom, has it without really thinking about it. That obviously, like, it did not cost him much financially, or it didn't cost him much of his time or much effort to reach this problem. It's very automatic, just like a reflex response. It happened very quickly, but there's a lot of other things that patient could have, and so it's really a low reliability, especially like we don't even have all the information yet, and there's a lot of different things that can cause weakness and low potassium. And a lot of times there's errors in this method. It doesn't take much effort, as we said. Predictive power, same thing as reliability. It's not very reliable, and it uses a lot of his emotions, and so his emotions, how the doctor's feeling at the time, could easily play a role in his diagnosis. And obviously, it's not very based on scientific thought or really analytical reasoning. And so when we look at the type 2, the analytical type, it's pretty much the opposite. So in analytical reasoning, there's a very systematic approach to it, which we'll talk about. It has the person or the doctor definitely is aware of what he's doing because he's specifically thinking about the problem and how to solve it. It has a high cost. Maybe it's a high cost because of studies that need to be done, like financial cost, or maybe it's just costing someone more time or a lot of energy. It's not automatic. It's actually very slow and trying to be as non-automatic as possible. It's a lot slower before we can get a diagnosis or decide what to do, but it has a much higher reliability and a much lower possibility of having different errors or the biases that we talked about at the last lecture. It takes a lot more effort, though, to force us to stop and think about why we're thinking, but because of that, it has a higher predictive power, and we're able to remove some of our emotions out of the decision-making process. And it has obviously a higher scientific rigor because it's going to be a lot more based on science and evidence, which is going to really help in the final decision. So there's this, you mentioned it before, but this dual processing theory. So dual processing theory means that this is really the clinical reasoning process is dynamic. Intuitive and analytical reasoning modes, they interact with each other, and a lot of times doctors go back and forth between the two modes. So we have a patient that presents, and then, or a case is represented in a certain way, and we're trying to figure out the best way to do it. And so a lot of times, so a patient presents with a problem, we have a first thought about it, and so we have a way we're thinking about the way that we're representing the case, and then we might start thinking about specific ways that we can verify whether this case is true or whether it's not true, and that might be done more analytically. And then if it's turning out that that hypothesis is not true, then we go backwards to figuring out, okay, is there a different way that we can think about this case? Do we need to go even back further and ask the patient more questions or do more tests and come up with a different conclusion and then test those hypotheses again? So it could just very much be going back and forth, where we're using both intuitive modes, like maybe in that other case, the doctor is thinking, oh, hyperthyroidism. But then now he's going to think, well, how can I prove that it's hyperthyroidism and not something else? So in the dual processing theory, it also says that the analytic mode can override the intuitive mode or vice versa. Like one of those modes can become stronger and affect the other mode. And also, like, as these processes go along, if like a beginning doctor in their first year, they might see something, a certain rash, and they might have to do a lot of exams and a lot of history taking, and so they're using a very uh, analytical process. But eventually, if they see that same rash over and over again, it becomes a pattern that they recognize. There's pattern recognition, which will make it will lead them to actually moving into the intuitive mode um, over time when we're talking about this specific disease or this specific rash. And so novices, that's what we say, they spend more time in the analytical mode, really thinking through things logically, but experienced physicians often spend more time in the intuitive mode because they have a lot of these patterns that they're recognizing. And so, is this good or is this bad? So, is it good to be an experienced clinician and just be spending more time in the intuitive mode, or is this possibly a bad thing? Um, so this would be an example. We'll go back to that question in a minute. Um, of a person that presents with a rash. Um, I don't know if any of you guys have an idea about what this is. And so if you don't, you would ask a lot of questions. You might take a biopsy or a scraping of the rash. You might spend a lot of time examining all the other organs to see if anything is combined with this, or spend a lot of time talking to the patient about the history. But if you've seen it a lot of times, you would know that this is shingles or herpes zoster, um, and just very quickly. Um, so the experience in this case, is that a good or a bad thing that I knew that just by looking at the rash? This is what we're talking about here when we're looking at an initial problem. We think about, does this fit any patterns that we have? And if it doesn't fit into any patterns, we start using our system 2 or our um, analytical process, and then from there we kind of do it. We think about it, come up with a diagnosis, and then make a decision. Um, but as we move up from becoming a novice to an expert, we're more likely that we are going to recognize this pattern. And so we'll just, if we recognize the pattern, we go into system 1, and we just go straight over here where we're making our decision quickly and um, not going through the analytical steps. Um, and so really, this could be good, this could be bad. It's great if you are getting the diagnosis right. It's great because it saves you more time and energy, and you can treat other patients in that way. And like, obviously, this is a great thing to have experience. But there might be certain times where really going through all the steps and asking all the questions and doing the entire exam might actually help. And so while we want to recognize patterns, it's also important for us to know that um, we need to also be maybe also be doing a double check and also be reminding ourselves to use our analytical reasoning even in a situation where we feel like we know it intuitively or we know the answer just automatically. It's still important for us to still do some sort of analytic reasoning to the decision-making process. So really, since both are involved, we need to learn how best to deal with system 1, this intuitive thinking, and system 2, the analytical reasoning. But one thing that has been studied is really like cognitive thought, meaning like um, uh, our critical thinking and our analytical reasoning, the way that um, we normally use that um, uh, a small fraction of the time. Way more of our thinking and our decision making comes from the intuitive part. So this is like an iceberg, and there's so much more of an iceberg under the water than above the water. And so really like this, all this part under the water, all this um, unconscious um, thinking or this intuitive thought, it's such a high percentage that it really shapes and structures all of our conscious thinking. So really, really, the most important thing is to probably understand the system 1 thought and how we can educate our intuition as much as possible, because that's really what's going to be informing the rest of our thinking. Um, so thinking initiatives, different ways to train our thinking. These are all different examples of ways that we can train our thinking. One is we can raise awareness of the importance of decision making, which really is this whole course, but specifically we addressed that in session 1. We can educate and train our intuition, which is what we're trying to do during this course, but also is something hopefully we're going to be doing throughout our entire lives. Promoting a reflective practice, we talked about this some in session 2, just as we're making decisions or implementing decisions, that we're reflecting on those decisions, not just the decisions themselves, but we're reflecting on the whole decision-making process that we used to make that decision. We helping our way of thinking is just teaching the main cognitive and affective biases. We talked about that in session 3, and then also ways to get over these biases that we might have. And then today we're going to talk more about this idea of just promoting critical thinking in general and promoting use of cognitive aids, things that will help us make good decisions. We'll talk about that in a little bit. And then we're not going to really talk about this as much, but but this is an important topic, is we need to know which conditions may compromise our decision making or may make our decision making worse. Things like just fatigue or being deprived of sleep or just having too much information or being too overwhelmed with information from too many sides is going to make it harder for us to make decisions. And so let's talk some more about this critical thinking and cognitive aids. And so when we're gathering our hypotheses, we get the chief complaint, say it's fatigue, something like that. We gather all our information based on our hypotheses about the patient's symptoms. And so maybe we ask a few general questions, but from there we start having an idea of, oh, okay, I want to make sure this is not diabetes or cancer or whatever. And so generally we start taking a more focused history and a focused review of system based on those that chief complaint. And then based on what our ideas are, we normally examine those specific symptoms or specific systems based on our ideas about what the disease might be. And really, when we have this, when we have a hypothesis in our mind, and then we do a physical exam based on that, it's really more effective because we're going to be focusing on the specific areas that might be involved rather than just doing a complete physical exam on someone that goes over all the cranial nerves and all the extremities and thyroid exam and heart and lungs and everything. One, we just don't have enough time, but two, it's just not going to be as good of an exam because we need to start figuring out what are the most important things rather than just doing the shotgun method where we just examine everything and we ask every question we could possibly ask about any problem. So before we see the patient, we see the chief complaint, the patient demographics, we have the initial problem representation, say it's fatigue or something along those lines. We have an initial hypothesis, like an initial idea. And we're at the same time we're scanning for different illness scripts, like we talked about. Like, does this fit any specific disease that we've heard about or have seen before? So then we move into the patient encounter, and we say, okay, we're going to gather all the data about the fatigue. We're going to do a physical exam, like a focused physical exam that might cover all the things about fatigue, and then order any labs. And then we're going to take all that data, we're going to bring it all together and analyze it, and we're going to refine how we're looking at the problem. So here we just had like, okay, fatigue, we don't really know. We have an idea that maybe this is, say, cancer. We get some history and physical exam in labs, and then we realize this has only been going on for 2 days, the fatigue, so maybe we're going to change we're going to analyze the data again and refine the problem representation. So we think, we don't think it's cancer anymore, we think it's diabetes, something like that. And so we've gotten to a new diagnostic hypothesis and really a differential diagnosis, meaning we want more than one diagnosis. Like we want multiple different diagnoses, and at the same time we're doing the same thing as above. We're scanning for different illness scripts, for different any key features or things about it. And then if we find that we need more data to come up with a better diagnosis, like it's just nothing's fitting, then we're going to go back and gather more data through the history physical examiner labs. And at some point, hopefully, we will find that one of our diagnoses does fit one of some illness script. Um, and then uh, we're going to get a diagnosis out of that we can at least start with. Okay. Now we're going to talk about these different cognitive aids for clinical reasoning. And so these are things that we can use when we're making decisions that might help us create a better differential diagnosis. Um, One is the pathophysiological approach. Sometimes people refer to this as the surgical sieve. Um, a sieve is something that like kind of narrows something down, or it's like wide at the top but narrow at the bottom, and so it is able to take. You can get ideas from a lot of different areas and then put them into one place. An anatomical approach or a systemic approach. So this is like specifically when a patient comes, we've taken a history or done a physical exam, or any time during the process. Um, I, we can, and we'll go over examples of how to use this. But this is very, very, very important. This is the first part we're talking about is more theoretical, but now we're getting very practical. And so if someone is coming in that is having fatigue or something like that, we can start thinking um, uh, maybe use a mnemonic like this: vitamin C, D, E. There's another one that vindicate, where each letter means something different or can remind you of something different. So we can start thinking, okay, does this person have any vascular problems, any infectious or inflammatory problems, any traumatic or toxic, like he ingested a toxin, problems, autoimmune problems, metabolic problems, iatrogenic or idiopathic problems. Iatrogenic, yani like something um, was caused by a surgery or by like something that the doctor had done to the patient. Um, the neoplastic problem, like a cancer, congenital problem, like something they've inherited from the time they were born, any degenerative problems, or any endocrine problems. So if we kind of go through those, we can create a differential diagnosis by trying to get any ideas from these different areas. And sometimes going through these different areas can help remind us of different causes of the symptoms the patient is having that we might not have thought about before. Another way to do this is the anatomical approach. Example for chest pain. What are the anatomical features in the chest? Okay, we have, if someone's having chest pain, there's the skin, there's ribs and muscle, there's the pleura, pericardium, myocardium, endocardium, the lungs and all the different parts of the lungs, and esophagus, aorta, spine, and exiting nerves. And so if someone has chest pain, we can think through what problems of the skin could be causing this problem, what problems in the ribs or muscle could be causing this problem, what problems in the pleura or the pericardium or the myocardium or the endocardium could be causing the chest pain, or what problems in the lungs or esophagus or aorta, or spine and nerves in the chest, what problems in these areas could be causing the symptom this patient is having. The systemic approach, and this is the approach that I normally use, it's just my preference, is I go through the different systems in the body and think through, are there any problems in any of these systems that could be uh, causing the uh, the patient's symptoms. So for the cardiovascular system, is there any uh, like a heart attack that could be causing the patient, a a aortic dissection, could this be causing the patient's problem? Respiratory, could it pneumonia, or could, or for CVS, could heart failure? GI, could it be Crohn's disease? Could it be ulcerative colitis? GU, could it be an infection? Could it be overactive bladder? Reproductive system, like is there something wrong with the semen or the sperm or the eggs, or just kind of go through each different area, each different system, and saying what problems in this area could be causing the patient's symptoms. So when we're going through our steps of clinical reasoning, first step, this is very practical as well. This last half of the lecture is something I want you guys to practice a lot. To take a complete history and perform the examination. Number two, we assemble the data in a way that makes sense. Then we review and reflect on the data and maybe read about the patient's problems. And so we're thinking about it, we're reflecting on it, we can be talking to other people about it, we can be reading about it, studying about the patient's problems. And then if we have any further questions or we need to examine anything else, we can go back to the patient, and then we can create a problem list. With number one being the biggest problem, it could be either the biggest problem in the patient's mind or in your mind. Then we're going to list out the differential diagnoses for each different problem, and with the first one on the list being the most likely cause of the problem. And for this, we're going to use our knowledge and just prior experience in general. And so at this stage, it's all about doing your best, which is fine. Even if you get it wrong, I think going through this process is going to help you in the future. Assess the defining and discriminating features. So we're going to weigh the sensitivity and specificity of the different findings, and we're going to consider all the different probabilities. And so if it's a male patient, we're going to say this is probably less likely that he would have breast cancer. We're not going to rule it out completely because we don't want to have a gender bias, but we're going to say, it's probably less likely. So that's less likely to be a problem than if it was in a woman. And then we're going to write down other actions that we want to do, like our plan. How are we going to further narrow down the differential diagnoses, different labs or imaging or different medicines that we're going to give, like our plan. So this clinical reasoning, this is kind of a little bit of a side note, but the clinical reasoning, this really starts at the bedside. It really starts when we're first seeing the patient. So it starts when we're taking a detailed and discriminating history and physical. Detailed meaning we're getting all the different details and all the information. Discriminating, and that we're trying to ask questions or do exams that are going to try to help us decide in choosing between if the problem is one thing or another thing. Like we're going to be asking more questions specifically about the heart and specifically about the lungs to try to decide, is the problem more in the heart or in the lungs? So an example would be if you think someone comes in, with a sore throat, and you want to know, is this more of a viral respiratory tract infection, or is it strep throat? So you might be asking specifically about, okay, do you have a cough? Do you have a runny nose? You're asking specific questions that are going to help you decide, is this strep throat or is this a viral illness? And then you're going to generate hypotheses as potential causes of the problem. And the clinical reasoning here is we're asking in our head, okay, what's going on here? What's causing it? And we're going to test those hypotheses during the history and physical. And then we're going to kind of try to group together signs or symptoms that might point to a specific hypothesis. If we have a viral URI, we're going to be asking someone about runny nose or cough or sick contacts, because we're trying to group these symptoms together in a way that can be explained by hopefully one diagnosis. And then, as more history comes about, we're going to be constantly refining those hypotheses, constantly thinking about the information critically and analyzing it to to have a better hypothesis about what's going on and what needs to be done. And of course, we're going to be using all our illness scripts and our prior experience. Like we're going to be saying in our head, have I heard of something like this before? Have I seen something like this before? And that's still part, even though that's a partly intuitive reasoning, it's helping in our overall process of clinical reasoning and analytical reasoning. So we'll do a couple examples before we end. So the patient story is a male, 54 years old. He says, I woke up from sleep with my left knee hurting last night. It was fine when I went to bed, but now it's swollen. It got bigger. It's the worst pain I've ever had. I've had problems like this before in the same knee. Once was 9 months ago and once was 2 years ago, and it doesn't bother me between episodes. I've also had a cough and a runny nose for a few days. So, do you have any things from the beginning? So if we look at his exam, he's afebrile, blood pressure and pulse are okay, his heart and lungs are clear. When we look at his extremities, we see that his left knee is swollen, and it's warm, and it's slightly red or erythematous, and then the right leg is normal. So if we were to summarize this patient, how would you summarize it? How would you just, if you were going to say this, tell someone about this patient in one sentence, what would you say? This is what I came up with. This is a 54-year-old male patient, and this does take some practice on knowing which things to focus on, but we need to learn how to talk like this because this is the way we can communicate with other doctors, and it also helps us in our own decision making to have it in a succinct, in a very summarized form. So a 54-year-old male patient complains of recurrent left knee pain, left knee pain and swelling since last night that woke him up from sleep. And he also has concerns about a cough. Okay, so the main thing, this patient has acute knee pain. So I want to read more about, this is the reviewing and the reading part. I want to read more about acute knee pain in adults. So I want to get a better idea of what might cause it. So upon reading, you find some main causes of acute knee pain are gout, osteoarthritis, rheumatoid arthritis, ligament injury, trauma in general to the knee. Okay, so do we have any other questions for the patient at this point? Is there anything else we want to examine? Maybe if we didn't ask him questions about fever or what else might we want to ask? Like length of time this has been going on for. Has he tried any medicine for it? We can go through the Socrates method. We can, just any other questions that we want to ask at this point. Any other thing else we want to examine. If we didn't do all the different anterior, posterior drawer tests, the meniscal signs, the McMurray's test. If we didn't do all of these things, we probably have to go back and do it at this point. So at this point, we can create a problem list. And so his main problems are he has knee pain. It's probably the number one problem. And second problem is this cough and a runny nose. So when we're creating a differential diagnoses, we can start writing down things. So we kind of talked about some of the things that you read about that could cause it. So let's add those to the differential diagnoses. And we're going to put the one that we think is most likely first. And you don't have to be right, but we're going to put the most likely one first, and then we're going to follow that with the others. So I put in most likely due to gout versus rheumatoid arthritis versus possibly trauma versus less likely osteoarthritis versus gonococcal arthritis versus sciatica versus cancer versus fracture. And then for the same thing, for the cough and runny nose, I would say it's most likely a viral upper respiratory tract infection versus probably less likely a sinus infection or strep throat or asthma. I'd put those a little less likely. And then we can assess the defining and the discriminating features about it. So we can kind of, I like to do this actually in writing and encourage my residents to do this in writing at the beginning, is, okay, number one problem, knee pain. It's likely due to gout versus rheumatoid arthritis versus trauma versus osteoarthritis. But if I'm going to just talk this, verbally process this or in writing, it's more likely gout or rheumatoid arthritis and less likely osteoarthritis because of its sudden onset. And it's less likely trauma because the patient doesn't remember anything. And so with a cough or a runny nose, or we had some of those other ideas, gonococcal arthritis, maybe it's less likely because the patient says that he's only slept with his wife, and he doesn't think his wife, and he knows himself, has not had any other sexual contacts. So cough and runny nose, we're thinking, like we said, it's likely viral URI versus less likely to be a sinus infection or strep throat. And it's also more likely viral since the wife is also sick, he tells us. It's less likely a sinus infection because, like he tells us, it's been less than 7 days. And it's probably less likely a sinus infection or strep throat because he doesn't have a fever. And normally those things would present with a fever. All right, so we've kind of talked about this through a little bit. This conversation could go on in a lot of different ways, but these are, for this example, some of my thoughts. Um, uh, Further actions. So at the end, I want to order an x-ray and I want to check a uric acid level based on these ideas that I had here. And then for the cough and runny nose, I would tell him, reassure the patient, because I'm pretty sure that it's a viral URI and less likely a sinus infection or a strep throat. So I just tell him, get plenty of water and get rest. And then so the last thing would be review. And so that's going to be monitoring the patient. So that's going to be following up with the x-ray, seeing the patient again after a few days, seeing if his cough and runny nose is better, looking at his uric acid level, seeing how his pain is doing, and continue to evaluate that process. So our second example is a 65-year-old female that comes to your clinic saying she's very thirsty and tired for the last month. She's lost 5 pounds in the last month. She denies any fevers or diarrhea or cough. She's afebrile, vital signs are stable. She has a dry mouth on exam, but other than that, her lungs and heart are regular and clear. So do you have any ideas already about this patient? If you have any ideas, that's probably your intuitive reasoning coming into play, which is not wrong. But let's first go through the analytical process. And so there's a 65-year-old female with weight loss, fatigue, and dry mouth for 1 month. So I want to read more about these symptoms and what disease might cause these. I just want to think about it. I want to talk to other people. I want to read about it. What kind of thing can cause fatigue, weight loss, and dry mouth? And upon reading, you find the main causes of, I didn't change this part, main causes of fatigue, weight loss, and dry mouth are what? I want you guys to give me some examples this time. Maybe you might say cancer, thyroid problems maybe. What else? If you have any ideas, what questions might you want to go back and ask the patient? Do you want to ask them more about does there any family history of thyroid problems? Do you want to examine the thyroid? Do you want to ask about family history of cancer? Maybe if you're worried that this patient might have cancer, do you want to ask them, have they had any blood in their stools, any blood in their vomit, any bone pain waking them up at nighttime, anything else like that. or anything else you want to examine. So let's create the problem list. The problem list is weight loss, fatigue, and dry mouth, okay? This is a lot of times how you'll be writing your notes too in the hospital. So let's come up with a differential diagnosis now for weight loss, fatigue, and dry mouth. What type of things that could cause weight loss? So what about if we think through our different the going back here, vitamin C, D, E. Are there any vascular problems that could cause weight loss? What about a uh, um, hemolytic anemia, something like that? What about infections? Yeah, like maybe any chronic infections could cause it, or any chronic inflammation. Trauma, maybe not so much, could cause fatigue, but I mean, I guess maybe like maybe you could say brain trauma, and then that having a neurologic effect. Toxin, if he's been ingesting alcohol for a long period of time. I know autoimmune problems. Yeah, a lot of autoimmune problems could cause this, like lupus or just any autoimmune problem, Lyme disease, um, uh, any autoimmune disease could possibly cause fatigue. What about metabolic problems? If his electrolytes are off, yes, that could cause it. Iatrogenic, okay, hasn't had any surgeries, but maybe he's taking a medicine or something that could be causing it. Um, Neoplastic, of course, cancer could be causing it. Congenital problems, we don't think so at this age. Degenerative problems, possibly, but we're normally thinking of a degenerative like bone disease or something that could cause it if he has a long-term arthritis or something, and now she's just so tired from the pain. Um, Endocrine processes, of course, thyroid things, of course, diabetes. We could do the same thing by going through any of these processes. Um, are there any problems in the or the systemic approach? Any problems in the cardiovascular system that could cause fatigue? Yes, we know that many problems in the heart, ischemic heart disease, valvular heart disease, could cause a lack of flow to be getting to the rest of the body. This is going to cause fatigue. Respiratory problems. We know that most respiratory problems are going to affect it. Like if someone's having COPD or asthma, they're not going to be getting enough oxygen to the bloodstream. That's going to cause disease. GI system, yes, I mean, if there's an ulcer, there's a bleeding from the GI system, that's going to cause, or a chronic infection, or a parasite in the GI system. GU system, maybe like an infection, um, central peripheral nervous system, that's going to cause fatigue. Yeah, maybe like a muscular dystrophy, maybe a demyelinating disorder, musculoskeletal problems, like if there's any rhabdomyolysis, that's causing weakness, obviously. Psychiatric, if there's depression or anxiety, that's going to cause it. Autoimmune, like we talked about, or hematologic, maybe anemia, maybe a cancer. Um, so you can see that you can really create a large differential diagnosis. So even on this first patient with the knee pain, if, say, we were going to go and do it with the anatomical approach, what are the different anatomical features in the knee? We have bones. What bones could be causing a knee pain? Okay, is there a fracture? Is there arthritis? What about ligaments? Okay, if there's a ligament tear or a ligament strain. What about meniscus? Okay, if a meniscus is torn or damaged. Um, if we look through um, like the fluid within the knee, the joint fluid, maybe there's crystals in there that's causing the problem, like from gout. Um, Maybe there's infection that's going on either in the bone or in the joint fluid itself. Maybe it's the bone infection would be osteomyelitis. Um, uh, There's synovitis, like the infection of the synovial fluid. Um, a lot of different things could be causing it. So maybe if we had done that, we could have gotten an even larger differential diagnosis for this patient. So in this patient, we did this for weight loss. We could do the same thing for fatigue, same thing for dry mouth. For fatigue and weight loss, we're actually probably going to get a similar list. Um, so as we're coming up with these different um, diagnoses, these are some of mine that I came up with, but obviously there's a lot more that it could be. And then we want to go through and talk about what makes one diagnosis more likely or less likely. So I would say that diabetes is the most likely because this could really explain all the symptoms and it's a really common disease. Versus, I would say less likely cancer. That normally doesn't cause dry mouth, but it can cause weight loss and fatigue. And so we should definitely still screen for this. What about thyroid disease? Well, the thyroid exam was normal, but it's still good to evaluate in someone like this. What about depression? Yeah, depression for sure. It doesn't explain all the symptoms, like it wouldn't normally explain dry mouth. And normally, if in depression there's not a huge weight loss, maybe a little weight loss, but maybe not as significant, versus a chronic infection, possibly, but there's not really like pain anywhere or fever. What about if they just change their diet? Um, Okay, we got to ask them about that. What about GI disease like um, bleeding or infectious um, uh, or bleeding, infectious, or what was the thing I was thinking? Parasite. Um, so fatigue, maybe all of those possibilities and many others, including there could be cardiac problems, respiratory problems, autoimmune or neurologic or hematologic diseases like anemia. But normally anemia is not going to cause weight loss. Um, so for dry mouth as well could be caused by a lot of these problems. But what about also just dehydration? Like it's just hot outside, or they're fasting, or they're not drinking enough fluids. Um, so further actions for all these different problems, I want to check a fasting blood sugar. I want to get a thyroid. I would get probably a CBC as well. Check for which screening for cancer and anemia. Um, Electrolytes, kidney function, urinalysis. We're screening for cancer, of course, for breast cancer or colon cancer or ovarian cancer. Um, we're going to discuss the diet. We're going to discuss any other GI symptoms with the patient. For fatigue, we're going to screen for depression. Fatigue is a hard one because it's so broad. And for dry mouth, we're going to encourage them to drink enough water as well as checking all these other things. Um, so the main thing that I want you to be seeing here is just how to go through the process. Um, this process here, taking a complete history and perform an exam, assembling the data, summarizing it, review that, say, do I need to read about anything else? Do I need to talk to anyone else? Then with that, go back to the patient, ask them if you have any further questions or examine anything. Then create a problem list. And then listing a differential diagnosis for each problem, with the first one on the list being the most likely cause. And we're going to be developing that differential diagnosis by using one of our other methods, like either the surgical sieve, the anatomical approach, or the systemic approach. And then from there, we're going to kind of talk through or write down. Um, um, we're going to talk about the different features that might make one diagnosis more or less likely. And then we're going to write down the further actions that we're going to take to narrow down the differential diagnosis. So for homework this time, there's a session 4 handout on OneDrive, and I'd love for you guys to complete that ideally within the next few days, but I'll give you up to a week from the time of this lecture to complete that. Um, and you can just send that in. Now we have a team set up on Microsoft Teams, so you can just send it in that way, and I'll be able to grade it a little easier that way. Let me know, of course, if you have any questions. Please be practicing. The session for handout is mainly practicing the different methods that we just talked about, thinking through different ways of getting differential diagnoses, and and uh, yeah, just thinking which one might be more likely, which one might be less likely. But the most important thing about this stage is just developing a broad differential diagnosis, and so you're going to try to not miss anything. Thank you very much.